We'll move on to the next talk on small change in the program. So we'll continue with the Dr. Satish Govind. He's going to talk on the atrial assessment on echocardiography, then followed by the cardiac MRI. Over to you, Dr.
Thank
Satish.
you.
Yeah.
Thank you. So I know it's lunchtime and behind schedule, so I'll try to quickly finish it as fast as possible. So this is about ATRIA and echo. And typically when we are looking at ATRIA, we are looking at anatomy, we are looking at measurements, and we are looking at function. So let us see how we sort of look at it from the echo perspective. Now, let me sort of give focus to left atrium. So that is the primary chamber. So understanding of the chamber itself in terms of its long axis, and especially when we are doing echoes, this is very important because we use the Doppler. We have to look. I always remember that the atria, the left atrium goes in the long axis in a different direction when you compare it with the left ventricle. So it's important when we are using the Doppler. And that is as far as the two chambers are concerned. Now, when you look at the left atrium itself, it has got a very unique shape. So typically it has been described in as a pillow shape, and it has this particular sort of a very unique way of dilating also in different directions. Now, a quick sort of review of the physiology. So here you have the flow which is coming into the left atrium. So you have the contractile phase during systole. This is the reservoir phase during systole here. And then you have the conduit phase when the mitral valve opens, and that is when the flow is happening, as you can see, very clear, nicely seen on the echo. And then you have the final phase, which is the contractile phase, where the left atrium contracts. So these are the three sort of very basic phases. Now, we sort of look at a lot of normal variants in benign conditions in the left atrium. So this is the list of it. And how does echo fare in terms of looking at the transplant suture lines? So this is how these suture lines look like. And sometimes they're not seen. And that is when we need to look beyond it. And we may have to sort of depend on the TE also. Then you have the Coumadin ridge or the Q-tip sign, and this is something which so often in the past, especially now that there's greater awareness, it has been mistaken for a thrombus. And this again, when there is a little bit of clarity is required, so we do the T. And again on T, sometimes it is very prominent, and you have this name of Q-tip because it is based on this commercial sort of earbud which is there, and it's also called as the Coumadin ridge. And what you see on the other side is the anatomical image and how the Coumadin ridge looks like. And then looking at the left atrial appendage itself, many times, especially when doing Ts, we look at the pectinate muscles and we sort of end up in some sort of a dilemma. Is it really a thrombus or is it the pectinate muscle itself? So this again is an area where we may sometimes depend on the CT to provide the differentiation, and the pectinate muscles can be a bit of a problem. Now, with the 3D, it can be helpful sometimes and sort of helps us in identifying. So this is this shelf-like sort of structure of the pectinate muscles seen from the left atrial appendage. Now, measurements per se, as far as echo is concerned, it has to be indexed to body surface area. So what is sort of normal for a short person may not be for the taller person, vice versa. And these are the parameters which we use routinely in the echo. And this is a time-tested, very old method. We look at only one measurement in terms of AP diameter. Lot of problems, lot of limitations, but still a lot of data behind it. And we continue to use, but we are aware of it, that it has got its own limitations. And that sort of has led into other techniques also. So then they looked at left atrial area. So this left atrial area has did really sort of provide us the answers what we sort of really wanted. And then finally, the big one that came for many years back is the LA volume. So this again is highly recommended, and which is sort of we are supposed to use it on a routine basis, but no. Most often you'll see in echo reports, this is not really reported. It's most of the times it is LA size, and that is where you need to sort of understand that the LA volume, which is the actually more accurate, is the missing data which is there. Now, in terms of data-wise, so this is how it is so well established in terms of how superior LA volume is. And with the advent of 3D, now we have automated LA volumes which are quite good, and provided the window is good. So this is a 3D image which shows you how automated measurements provide you with a lot of values, numbers over there. Now, with the advent of a strain, which Dr. Shanmugam nicely pointed out, so we have sort of a newer tool to sort of look at the LA. And this again is now a dedicated software which was not available. So very quick and easy way of doing the LA strain. A lot of interest now, a lot of people are looking at it, a lot of focus on it. There's a lot of clinical value which is being associated with it. So it's very simple and a typical 4-chamber. And you can see that there are different types of atria. You have a giant atrium over there and you have a moderate sized atria. So just a quick acquisition and the software which is there gives you 3 sort of values: reservoir, conduit, and contractile strain. So that's how the LA strain in terms of the LA is looked at. Now, how is LA strain going to be helpful? So it has been, we are sort of looking to make it more reliable in terms of can it predict atrial fibrillation? The data is there, but we need more data. So there are some numbers which are sort of we are using to say that beyond a certain number, below that, the patient is at risk of having atrial fibrillation. And also in terms of looking at the beyond LA volume itself. So again, looking at LA strain. So many times, even in normal LA, in this particular sort of a study, looking at the LA volume. So even though the LA volume was normal, but the strain showed that they were at risk. So this is looking at the ERIC study and in terms of the heart failure with preserved ejection fraction. So it has got its own value in terms of LA strain. And of course, not to be left behind, this AI is going to be there. So it's still early days. So of course, probably in a couple of years, we are going to hear more about it, both in terms of looking at, in terms of automated measurements and providing some sort of a prediction, and also trying to identify what are the phenotypes which it can provide. This is with deep learning. And looking at masses, a very brief look at how we use contrast. Sometimes we have these masses in the left atrium. So this is again use of the bubbles here. So if the mass is vascular, the bubbles have to get into the mass, and that's how we say it is a vascular mass or avascular mass. So this is a typical myxoma here, where partially it is sort of vascular, and you can see a few bubbles. So just an example of how masses are identified in the left atrium with the use of contrast. Now, quickly moving on to right atrium. So your right atrium is more difficult in terms of a lot of abnormal variants. And this again has been mistaken for a lot of pathologies. And that's why we sort of end up having a lot of need for the imaging modalities in terms of the MRI and CT over there. So this is a close-up view of how the coronary sinus actually looks like. So this is the eustachian ridge over there, and you have the IVC2 orifices close together. And when we sort of look at it in terms of transthoracic, you can see the eustachian valve very prominently seen in the lower image. And in the esophageal view, which are the top images, you can see again that the fluttering sort of movement, that is the eustachian valve, which is seen over there. And incidentally, the first image shows an atrial septal defect, and the other one shows no defect over there. But the main thing is to look at the eustachian valve, and that is how we identify on TE as well as transthoracic. And then this is by 3D. You can see that this flap-like tissue which is over there. So that's how the eustachian valve looks like. And this can be better appreciated with 3D TE. And the Chiari network once in a while sort of pops up, and you can see that very fenestrated sort of, fluttering, moving structure over there. And this most of the times in transthoracic, it can be identified. Of course, on TE, it is better seen. And the one which sort of really gives a lot of grief in terms of the problems is the crista terminalis. So many a times these patients are referred as masses in terms of thrombus or tumors. And you can see that this often is mistaken on transthoracic many a times to be a thrombus or a tumor. So this will come to you as imaging, to find out whether it is really a tumor or whether it is a thrombus or something else, or whether it's just a normal variant of crista terminalis. So this is how it looks like on the transthoracic as well as on TE. And that is, again, something which needs to be sort of kept in mind. And the suture lines, again, on the right side, I guess, is similar to what I mentioned on the left side. So may be seen sometimes, may not be seen. And that's how it looks like on the transthoracic. Lines and leads are a big problem, and we so often sort of are not unsure many times, and that's when we need to sort of look at the CT, we need to look at the PET, so in terms of the various pathologies which are associated with it. And 3D, of course, gives its own perspective, so you can see that it gives you a really nice sort of spatial understanding of what's happening with the lead. And then the right atrial appendage, not much to be sort of focused upon, so not much sort of to be there. But once in a while, we sort of get these prominent pectinate muscles, and for somebody who's not experienced or not aware of it, so they can mistake it for some sort of a tumor or some sort of a thrombus over there. And this again has been mistaken and has happened. So we have to be aware of this. So in this particular patient, there's a very prominent pectinate muscles over there. And this again is looking at it from the 3D. So it gives you some images of how the pectinate muscles looks like going into the 3D, going into the right atrial appendage over there. And then the other indication, I mean, the problem sometimes is there is this bright mass which is over there. This is the lipomatous hypertrophy, the tricuspid annulus, again mistaken for tumor, and then again this is sent for MRI. So this again is how it looks like on transthoracic echo, and this can be mistaken for masses over there. And now looking at the coronary sinus. So coronary sinus, again, sort of very limited views, but fairly well seen. And of course, MRI is sort of useful in many ways. So this is, again, coronary sinus, how we look at it. So this is in one view. And again, sort of video loops here showing how it is, if it is dilated. And we sort of use the contrast bubbles also to see where the bubbles come in terms of the LSVC. So these are sort of glimpses of how the coronary sinus looks like on transthoracic echo. Now, how do we look at the right atrium? So there are some standardized views. So we have this, what we call as the Patterson long axis modified views. So the lower one is the right atrium. So this is from one view. And then again, you have the short axis. Again, the right atrium is seen from another cut here. And going beyond, so we use the fourth chamber and look at it from a different angle altogether, and then we go down and look at the right atrium from the subcostal view. So sometimes this can be a problem in terms of the window itself, and that is when we sort of end up, especially the right side can be a real challenge in terms of imaging. And how do we assess in terms of measuring the right atrium? So there is this area which is now getting more and more sort of prominence in terms of predictive value, especially with pulmonary hypertension coming into play here. And then you have these linear dimensions. They have their own limitations. So looking beyond it, volume, not much of data, so we don't use much of it. So there's no dedicated or standardized way of looking at RA volumes. And the RA strain, some sort of data is coming in terms of numbers, but still early days. There's still no dedicated software, but some normal values are being sort of published. Let's wait and see as far as the strain is concerned. But right now, it is just the linear dimensions and area which we use on a routine basis. So challenges as far as the right atrium is concerned is the window, and again the normal variance, and then you have these lines and leads over there. And in terms of contrast, so sometimes you use the contrast to look at the masses here. So here you can see a thrombus over there because it's avascular. It does not take any bubbles into it. So you can see that it's a very dark structure, and you can confidently say that this is a thrombus. But it has its own limitations. So sometimes there might be some situations where we may not be very accurate in terms of identifying this mass. And this again is a vascular mass. So this is a metastatic mass. You can see that the bubbles have been pushed in, and you see that the mass totally disappears. So that means a lot of bubbles are getting into the mass, and it tells you that it's a vascular mass. So this is a metastatic lesion over there. So this is the role of contrast as far as looking at masses are concerned. So my final slide is when we look at ATRIA in terms of echo, and obviously from the imaging from your side also. So it is going to be looking at anatomy. We are looking at measurements, function. And from the echo side, we look at TT as the first line, and we use 3D to some extent. Strain, still early days, but LA has got a lot of data coming in, and 3D as far as T is concerned has got its uses. Challenges, especially the right side in terms of windows and normal variants are there. And of course, we are going to use T anytime there is a question that is unanswered or there is a dilemma. And beyond it, we are going to definitely seek your help over there. So thank you once again for your kind attention, and that is my presentation.
Thank you, Dr. Satish, for showing such a wonderful 3D pictures, excellent collection of cases. So I thank about Dr. Satish as well as the Indian Association of Echocardiography on behalf of Indian Association of Cardiac Imaging. And we are looking forward to have more such collaborations with IAE. So
thank you. I would like to make one comment. So, I mean, I would like to say that we are not competing imaging modalities. We are complementary to each other. And I think we should continue in that path. I think it's great to be associated with the Indian Association of Cardiovascular Imaging. So best wishes to this conference and to the future also. Thank you.
Thank you, sir. So on behalf of Dr. Satish, Dr. Vimal Raj will collect the memo.
Thank you.